So first, we're going to be looking at hypertension today. And then if we have time, we will also be looking at dyslipidemia. The question is always, which guideline do we follow? And at the moment, the challenge is the standard treatment guidelines and essential medicine list for the hospital is from 2019, which in modern medicine world is quite old. So 4 years is quite old for a guideline before it's updated. And the National EML Committee is in the process at the moment of updating the section on cardiovascular diseases in the EML. And we were actually hoping it'll already be out this time of the year, but it will definitely at some time this year, the new EML will be released. So being able to look at what we have, the main guidelines that we've still been following and which our current EML is based on is a guideline that came out in 2014 by the Hypertension Society in South Africa. And so we will be looking at some of that. There's also been a lot of things happening in the international sphere of hypertension, and that's going to be influencing our NEML. And I was very fortunate last year to be part of an NEML meeting where they were giving us a preview of what changes we can expect. And so I'm going to give a little bit of a combination of where we're at and where we're going with hypertension. We are not moving massive goalposts, so nothing dramatically is changing. What is changing is we're getting more aggressive in getting people to target. So we're still using the same treatment. We still got the same basic steps, but we're going to be a bit more vigorous in trying to get those blood pressures under control. So our current diagnosis for hypertension, as you know, we're still using 140/90 as our cutoff. And internationally, that cutoff is currently the thing that's under hot debate. Should we be using 135/85? And certainly what is happening in the international guidelines is that there are certain conditions. For example, if you've got diabetes with complications or you've had cardiovascular incident like a heart attack, where they might set a lower target. In South Africa, we're not even reaching the 140/90 very consistently. So the decision has actually been made, let's rather do 140/90 well than starting to set all kinds of idealistic targets as they are doing overseas. Very important is we are looking for somebody who has a consistently high blood pressure because they've got atherosclerotic disease. So because their vessels are clogged up with all kinds of stuff, the heart has to work a lot harder all the time. All of us has times in the day when our blood pressure might go a little bit over the 140/90. So if you've just hit your finger with a hammer, or you're very upset, or you've just run around the block, although that might make your blood pressure go down as well, or if you've just had some caffeine, there's all kinds of little things that makes our blood pressures go up and down during the day. And as long as it comes down to a nice steady baseline, that is not a problem. That's not hypertension. And this is why it's important when we do our blood pressures that we do our blood pressures correctly and that we have a few blood pressures to make major decisions on. So that's why you can't just do a blood pressure and go, oh, look, it's up, and then start treatment. And quite often we see patients ending up on a lot of treatment because we're treating what it says on the machine and we haven't actually checked, is this actually evidence of this person having blood pressure? So the diagnosis is must be consistently over 140/90 over at least 2 to 3 visits using the correct technique. And I think all of you know the classification. That's from that 2014 guidelines. So we normally talk about grade 1, 2, and 3. And there is this concept of high normal, which is creeping in, which is between 130 and 139, or between 85 and 89, where we're saying, well, maybe we are on the way to it becoming a risk, and maybe that's significant for certain populations. But in our setting, we still have grade 1, 2, 3, and that isolated systolic, and that I assume you all know very well. So this is the algorithm, the 2014 algorithm on the left here that we still use. I'm just going to briefly describe it, and then I'm going to go into detail on what the new EML one looks like. Basically, what happens is we need to decide how aggressively do we come in with treatment. And we basically usually classify people on 3 levels. We either have the very low risk patients, which is the grade 1 hypertensions that's got no risk factors. And in this old guideline, they had less than 3 risk factors there, you can see. Then you've got your moderate risk. So those are people with risk factors or slightly higher blood pressures. And then you've got those with blood pressures over 160/100, which would be sort of a high risk. And depending on those risks would be how aggressively you will come in. And I want to show you what the new NEML is going to be recommending. Interestingly, even in the 2019 guideline, they make the note that most people are actually going to end up on combination therapy. And that is where we're heading. That instead of, starting on 1 tablet only, a lot of patients, we are actually going to be starting on dual therapy. And that's probably the most dramatic change that's happened in the last few years in hypertension. And when you look at practice, there's very few patients that you're going to have that you're going to be able to control on only hydrochlorothiazide. So this is a little bit what the actual algorithm looks like. Sorry, it was a screenshot from the presentation. And there might be slight changes when the actual final guideline comes out, but it's a principle that's important. So on the left here, you will see we're talking about grade 1 or low risk hypertension that's got no other risk factors. And you'll notice on the bottom here, there's little steps that's being described. And the steps are very simple now. Step number 1 is low dose single therapy, like that's your hydrochlorothiazide, right? Next step is low dose dual therapy. Third step is full dose dual therapy, step 3, and then step 4 is triple therapy, and step 5 is what we call resistant hypertension or triple therapy plus, right? So that's your very basic steps. And how it works is that with mild, when you're with low risk, which is actually very few of our patients, you can get away with that low dose single therapy. With your moderate risks, so those are the guys who've got some risk factors, and we're going to look at those in a minute, then you're going to actually start on low dose dual therapy. So you're going to start with 2 treatments at the lower dosages. And then for those that have already some cardiovascular disease or very high blood pressures, your severe patients, they can actually go on to full dose dual. So those are your 3 options, basically. With your very low risk patients, you also still have the possibility, especially if they're young and there's no other risk factors at all, to try lifestyle before you start. So you can have a month or 2 where you try some lifestyle, cut the salt out, get them to do some exercise, especially in your younger patients, before we put them on treatment. But generally, a lot of patients are going to fall into 2 and 3. So let's just talk about these. So that's just a summary of what I've just said. So 140/90, no risk, low dose single. As soon as the blood pressure is up, low dose dual therapy, or if they've got risk factors, if the pressure is very high, full dose dual therapy. And that's initiating on treatment. So a big part of deciding how aggressively going to be in is how much is my patient at risk of cardiovascular disease. This guy going to drop dead from a heart attack tomorrow. And there are lots of risk graphs. This is the one that the NEML, this is very familiar from also the international guidelines. And you can see on the top here, I want you to just notice they've got a high normal there listed. And then for particular patients, especially those that's got, like, for example, already established cardiovascular risk disease, even that slightly increased blood pressure puts them in very high risk. For our patients, you've noticed there, if you've got a mild grade 1 hypertension and you've got no other risk factors, that we could still call low risk. But as soon as you've got 1 or 2 risk factors, you're already up to moderate risk and you qualify for that dual low dose therapy. Makes sense. And then more than 3 risk factors is moderate to high risk. Okay, so what does the risk factors look like? These are all the things we know. This is what's listed, and the list will probably gets adjusted every now and then, depending on which guideline you look at. And it's just to emphasize that you want to look at how many risk factors does my patient have. So obviously smoking wins your risk factor. Dyslipidemia, so if you've got a cholesterol that's over 5.1 or LDL over 3, they've given like particular levels there. If you've got diabetes, obviously, in particular age groups, as soon as you're older, over 55 or over 65, in women, if you've got a family history that has a history of cardiovascular disease in the family. And then abdominal obesity, very important. And in the guideline we have in the EML, they still specify in men that 102 centimeters and 88 centimeters in women. But I think that threshold is dropping. So 94 centimeters and 80 is becoming more acceptable in terms of that's already a risk factor for cardiovascular risk. And notice for some populations, those waist circumference is even lower. And this is some of the things that might be in the new EML, and people also constantly a little bit tachycardic, and people who have early onset menopause will also be considered risk factors. So as soon as you've got 1 or 2 of these, then you might already qualify for low dose dual therapy. And that's pretty much all of our patients. But you might also have those patients already that have complications, and they definitely qualify for dual therapy. So those that already have indications of left ventricular hypertrophy, so we can see the hypertension is already done damage. If they've got microalbuminuria, so that's a UPCR of what we call a moderate proteinuria between 0.015 and 0.05, and if there's some early retinopathy. So these are HMOD, so hypertension-mediated organ damage, and together with that is people who've got known cardiovascular disease. So if they've got coronary artery disease, they've got heart failure, they've got confirmed chronic kidney disease with a GFR under 60, they've had a stroke or a TIA, they've got peripheral artery disease, or they've got advanced retinopathy. So all of these, we are looking at dual therapy, either low dose dual or full dose dual, depending on what the situation for the patient is. Simple, easy, cool, moving on. So your baseline assessments for all your hypertension patients. So now we understand what we're looking for. So you can't decide what level of treatment you're going to give if you haven't identified the risk factors. So obviously do the waist circumference. Do you all know how to do a waist circumference? Yes, no, vaguely, somewhere here. So you find the top part of the hips, you find the bottom part of the ribs, and you find the midway in between. And that's the waist circumference, those typical values. Then the 9488 is based on that. Remember baseline ECG, so we can see if there's any evidence of left ventricular hypertrophy. We do a urine dipstick. If there's any protein, we send for urine PCR. Okay, so because we're trying to figure out if there's already damage. And those are our baseline bloods. So you need to do a cusp, you need to do a full lipogram, and we need to make sure our patient's not diabetic. And sometimes if they've got history of gout or you're concerned about uric acid, you're also going to do some uric acid. So our treated target, we are still using that target blood pressure of 140/90. There might be some patients where you may decide, and that's also, I think, in the guidelines, they might give us more guidance on that. If you've got a patient who's got diabetes with severe chronic kidney disease, for example, it might be sensible to go for a slightly lower, lower target even. So remember, I've said you're always going to check your blood pressure at least twice using correct technique. You're going to review your patient every 2 to 4 weeks until that blood pressure is on target. So ideally, we should be seeing people every 2 weeks. It depends a bit on your patient. If your poor patient can't come in every 2 weeks because it's expensive to get to the hospital, then you might do 4 weeks. But you don't want to do this while we start you on treatment now and we'll see you in 3 months' time. We want to see them regularly until the blood pressure is on target. If they're obviously less than 40 years old and they're suddenly presenting with hypertension, they need a full workup for secondary causes, and you can go and look that up. So this is our steps. I think hopefully most of you are aware of these. I'm going to go through these quite quickly. Do look these up in the handy reference tools when you've got the patient in front of you. So still standard, almost everybody will be started on hydrochlorothiazide as their first step if you're able to use monotherapy. Remember, that's only in very low risk patients. And we use usually 12.5 milligrams is the dose. We don't really use the 25 milligrams for hypertension control because it doesn't do much extra over the 12.5. The only times you might use 25 is when you want a little bit of extra diuretic effect, like in a heart failure patient, for example, but otherwise 12.5, patient's not on target, you're going to move on to, remember we talked about low dose dual or full dose dual. In our population, we usually add amlodipine, and your low dose dual would then be 5 milligrams nocte, or in certain indications, we'll look at those, you'll use enalapril. So it's either the choice between the two, that's usually 10 milligrams for your starting dose. And then you can increase that dose every 4 weeks until that target is reached. So amlodipine can go up to 10. And for hypertension, we can go up with enalapril up to usually 20 milligrams per day. And then you usually go up because otherwise you're now getting into BD dosing. I mean, heart failure, for example, we do use the enalapril 20 milligrams BD. So this is just a couple of highlights. I'm not going to go through all the lists, then you're definitely all going to fall asleep. But just remember with hydrochlorothiazide, not good friends with gout. So if somebody's got gout, hydrochlorothiazide might make it worse. And we can't use hydrochlorothiazide if they've got severe kidney disease. So as soon as that GFR drops under 45, we usually switch this out for furosemide. So sometimes you'll see patients on furosemide for blood pressure, and it's for that reason. Amlodipine, we know actually is better than enalapril for our African patients. So that's why it's normally our second choice. Great for isolated systolic hypertension. Our elderly patients, they quite often have that. But just watch out a little bit for patients with heart failure and tachyarrhythmias, then you're rather going to be using your enalaprils. Great. So we've got patients on 2 treatments now. They're still not on target. You've done your blood pressure correctly several times. And now you can add enalapril or amlodipine and titrate them up to maximum dose. So they will now end up being on hydrochlorothiazide, amlodipine, and enalapril. And at this point, you can decide if you want to try that hydrochlorothiazide 25 milligram max, but there's usually not much benefit. Usually when you get to this point, you will say, we've now got them on maximum triple therapy for their hypertension. If they fail at this point, this is what we call resistant hypertension. And with resistant hypertension, we now want to make absolutely sure that this patient's blood pressure is also high at home and not just here. So now it becomes, we've had discussions before of whether we shouldn't have a little electronic blood pressure machine we can lend patients for a month and get some blood pressures at home. Normally what we ask patients to do is to go pop in at a clinic and have their blood pressures done at the clinic. Because your worry is that sometimes people are quite stressed, they get quite jittery when they come into the front, they find the whole hospital thing a major challenge to do. And so whenever they see you, the blood pressure is always up. But back at home, it's actually fine. And what happens is everybody loads and loads and loads the script. And actually, maybe their issue is they actually might not have as bad blood pressure as you think. So before we get to resistant hypertension, we need to make absolutely sure there's not white coat hypertension. So our fourth drug that we add, so this is our triple therapy plus, is spironolactone. And there's some good evidence that in resistant hypertension that sometimes does the trick. And you can titrate that dose right up to 25 milligrams. So just enalapril, if you do have patients with heart failure, or you've got patients with nephropathy, so lots of proteinuria, then enalapril is definitely our first choice over amlodipine. So that's where they're particularly good. The problem with enalapril is hyperkalemia. So those of you that might have forgotten, anybody you start on enalapril or anybody where you increase the enalapril, make sure you book them 2 or 4 weeks later. 4 weeks is still okay usually, to just repeat that potassium and make sure that that potassium is still okay. So that is one of those suable things. You don't want to miss a hyperkalemia in a patient you've put on enalapril. Sometimes the creatinine can go up on enalapril, and that's okay. We give like a good 20-30% leeway for that creatinine to go up a little bit. So you'll keep an eye on that. But by far the biggest problem is usually the hyperkalemia. And then of course the cough. Some people get this frustrating cough. Losartan, interestingly enough, we usually use losartan only when enalapril, for example, if it causes a cough or causes trouble. But for example, losartan is specifically gout friendly, which is quite interesting. So if you've got a patient, it actually reduces uric acid levels. So if you've got a patient with gout, losartan might be a good choice for their hypertension. And then spironolactone also is one of our key drugs for patients with heart failure with reduced ejection fraction. We just can't use it in very low eGFRs or in high potassiums. So if you've got a patient who's got hypertension and heart failure, they're going to end up on spironolactone as well. So that's very nice and clean. But now you have all these lovely drugs, and now people have problems. They either have side effects or on one of the drugs that they've been taking, or you get to the point where none of them, or they're still not controlled. And then we've got a few other options. Hydralazine is a nice drug to remember, especially because we can use it in very low GFRs. So the dose there, though, is at 3 times a day dosing. And that's probably the biggest reason why we don't use hydralazine in the first 2-3 steps, is because it is TDS dosing. And you can go up right to 75 milligrams 3 times a day. Remember, in our patients who's got BPH, doxazoline is a great option. And those patients who's got, again, heart failure, reduced ejection fraction, they will also need carvedilol. And so then you might use your carvedilol as a replacement. And then I've mentioned earlier that if you can't use your hydrochlorothiazide due to a low GFR, then you're going to use furosemide. And in the handy reference tool, we've got all of these things summarized in these little tables. Just a little thing, remember with the beta blockers to watch out with your asthma COPD patients. So we have to look at the whole patient before we add things in. So once your patient is now nicely on treatment and nicely on target, how often do we actually do the blood pressure? So you're obviously going to do the blood pressure each time they come, and we're going to check for side effects. And our focus is very regularly until they're on target. But once they're stable and the blood pressure is under 140 over 90, nice and reliably, then we can actually get away with a visit every 6 months. While we're working them up, especially in the beginning, there's some things you want to keep an eye on. So you can obviously keep an eye on that creatinine. You want to keep an eye on that potassium, especially if they're on enalapril. But with all of your diuretics, it might affect both the potassium and the sodium. And you want to do your urine dipstick. And we're going to talk about lipograms in the next presentation. And then once a year, so we also need to become aware of, you don't have to do all the bloods every time you see the patient. So only once a year do we need that ECG. Urine PCRs, we really don't change the treatment because of a urine PCR. So there's no point in doing the urine PCRs every 3 or 6 months. Once you've confirmed the patient's got severe or moderate proteinuria, you can do a yearly urine PCR. And always remember to check when you examine your patient for signs of end organ damage. There's also a lovely table. This is also in the handy reference tools. Hypertension often comes with friends, and when it comes with specific friends, then there's particular choices of blood pressure. So we've already mentioned, for example, in our heart failure patients, they're all going to end up on enalapril. They all going to end up with reduced ejection fractions on carvedilol and spironolactone. So you want to treat your hypertension with those 3 drugs as well as priority. Just a note here that protease inhibitors and amlodipine are not good friends, but we are slowly busy getting rid of protease inhibitors. So fortunately, that will become a problem of the past. And then just the last few slides on severe hypertension. So these we often see down in Ward 5. The nurses have written in, they've done like those 3 blood pressures, and the tummy is coming in and it's like 192 over 112, or it's 108. So you get these when they're like slightly high, but the patient's completely asymptomatic. She was completely unaware of this even being a problem. Patient gets jumped to the front of the queue. Do not get tempted to now start and trying to get the blood pressure dramatically down on the day. What's the point? They've obviously been running with this high blood pressure for a while, and now trying to get the blood pressure down for a few hours to make yourself feel better, this sort of amlodipines, etc., which takes a few hours to work anyway, is more to make us feel better than the patient. What you do want to do is let the patient rest a little bit, and you want to repeat that blood pressure after an hour. I did have a slide on correct technique, but that obviously did not make it into my presentation. So if you've got patients, please do the blood pressures yourself. Make sure they've not eaten in the last half an hour. They're not had caffeine. Make sure the bladder is empty. Make sure they don't have pain. Please don't take a blood pressure seriously if somebody's got a massive headache or sore toe or whatever. And if they're a new patient, this would be an indication to start that patient on 2 antihypertensive drugs. So start them on dual therapy, and you're going to follow them up within a week. But there's not necessarily a massive focus to get that blood pressure down on the day. Where it does become important is if they've got symptoms. So this we call hypertensive urgency. And this is a patient who's actually got quite a severe headache, so much so that they're really struggling with it, or that it's affecting their functioning. If they've got short of breath with a high blood pressure, or they've got edema with a high blood pressure. So these are not immediately life-threatening complications. So it mustn't be edema where the patient's actually got their sats dropping, but the patient definitely has got quite marked symptoms together with their hypertension. And interestingly, in the guidelines, we're supposed to admit these patients. So if you are going to focus on getting that blood pressure down because you're concerned that the blood pressure itself is making them sick, you can't do that as an outpatient basis because our drugs take time to work. So they will be treated with 2 antihypertensive drugs, and you can see normally we bring that blood pressure down over 48 to 72 hours using our usual drugs such as amlodipine and enalapril, etc. The emergency ones are the ones with life-threatening complications. These are usually quite obvious. So your hypertensive encephalopathies, a guy who's coming with a heart attack, somebody who's got severe acute heart failure, obviously our eclampsia patients who's got acute renal failure with actual encephalopathy, or if you've got something like an acute or aortic dissection. So these patients obviously is going to go to ICU. And that's when they start using your IV labetalol. And there's a whole very specific protocols that get followed to bring the blood pressure down at a very specific rate. So it's very, very carefully monitored to bring the blood pressure, because you want to reduce the risk, but you don't want to bring the blood pressure down too quickly because the patient might compensate in another direction. So this is not for us. If you are in a district hospital setting, you might manage the hypertensive urgency certainly in your ward. And the emergency, if you're going to have to manage in your ward because you're out of the sicky, you're going to do it with a physician on the other side of the line every half an hour and going to get some support. And if possible, you're going to refer that patient up to a place that has got high care or ICU setting. So that was a very brief summary on hypertension. And as you can see, I have not covered any detail. That's please up to you to go and read up. I've not covered any of the complications or weird and wonderful scenarios, but that gives you at least a good indication of patients you're seeing in the ward today and how we manage those patients. Okay, thank you. Any questions about hypertension? Oh, and I get a clap for that. Excellent. Should we do all the comments and things at the end, or any urgent things we need to correct at this point? Okay, my recording, good. So we stop here. And my recording is still working bizarrely enough. So let's